All right, welcome to another episode of Nobody's Perfect podcast. We're here with Dr. Arturo Taca, and my co-host Michael Jones is here. Michael, good to see you. Dr. Taca, good to see you as well.
Nice to see you both.
Thanks for joining us. We are here to talk today about something that I think is important in the addiction space, and that is the fourth wave of the opioid crisis. Dr. Taca, tell us, what does that mean? What does that refer to, the fourth wave?
Okay, so we've been in the grips of an opioid epidemic the last 20 years or so. It started out as a issue with opiate pain pills when we were very or overly ambitious in treating pain with prescription pain medications. And that led to a rise in overdoses and in deaths. And what occurred after that was an influx of more powerful, more cheaper opiates in the form of heroin. And so the Mexican cartels who were distributing marijuana and cocaine had already a network of distribution places around the country, and thought that, hey, we can supply the needs of America, who are mostly addicted to pain pills, with our cheaper heroin. That was the second wave of the opiate epidemic, and we saw a lot of suddenly heroin was considered a kind of a drug of not the people who were disenfranchised and in the gutter. It was kind of a suburban problem. All of a sudden, people in high schools and cheerleaders and housewives and people with good jobs suddenly were addicted to heroin because of their previous addiction to opiate pain pills. And then the third wave came after that, when the appetite of these people were not being satisfied with heroin. And so fentanyl came into the picture, and fentanyl was at times gotten legitimately it was the source was from legitimate pharmacies and peddled on the streets. But what had happened was labs had started making that in their labs, and they distributed fentanyl because people weren't getting high anymore on the heroin. So heroin suddenly disappeared. And so that was the third wave of the opiate epidemic. Now we're seeing a different combination of drugs on the street, which still includes fentanyl. But the scary part of this new wave of supply of drugs is the introduction of methamphetamine and fentanyl to the mix. So now we're in the fourth wave of this growing epidemic. Actually, it's not showing any signs of slowing down.
And when you say labs, you mean like the cartels labs, right? Not big pharma lab or anything to that effect.
Correct. There's an interesting story behind fentanyl. Fentanyl was actually discovered and invented by a guy named Paul Janssen. Paul Janssen was this brilliant pharmacist who discovered molecules like haloperidol and risperidol, the first antipsychotics, and and loperamide, and a lot of other groundbreaking medications. His lab was eventually bought out by Johnson and Johnson. So Janssen was originally a pharmacist and became big pharma when he had these discoveries, these big blockbuster drugs developed. And he actually discovered fentanyl. And so what he did was he had dozens of analogs of fentanyl, and actually went to China and went to the Chinese government and said, "I'd like to develop these molecules with you." And so they had the secret recipes for fentanyl for decades. And what they figured out during this whole epidemic was, we don't have to grow marijuana. We don't have to grow heroin. We don't have to grow cocaine. We can synthesize fentanyl because we've had these recipes for decades. And so these illicit recipes sat in China for years, I suspect moving forward, what we're going to see in America, the drugs that we're going to be seeing that are going to be illicitly distributed are going to be synthesized in labs. I just don't think that the drugs that we grew up with, the things that had to be grown that required fertilizer, that required 6 months of growth and farmers being involved, that's behind us. It's much more efficient, much easier to turn a profit when you can make these things quickly in the lab. So that's what's happened. They've discovered that fentanyl and its analogs are easy to make and easy to distribute. The networks are already here, and it's a lot easier getting small packages of fentanyl in a package versus pounds and pounds of raw material like heroin or cocaine or marijuana. So they're made in China, sent to Mexico, and they're utilizing the network that's already been established over years and years of drug distribution. So it's kind of interesting because once upon a time, methamphetamine was a party drug. It was a drug specifically growing up. If you remember, the people who were using methamphetamine were mainly bikers from California, like Hell's Angels. And then it saw a popularity growth in the gay community. So methamphetamine really was a party drug, but now the methamphetamine that's on the streets it's made differently. It's much more toxic to the brain, and it's being mixed, distributed, and sold together with fentanyl. So this fourth wave it's not only opiates. It's a combination of lethal, very powerful opiates mixed together with really toxic forms of methamphetamine, and oftentimes you can see them in the same pill.
There's a lot of things that you said there that are interesting to me. I mean, first of all, the history of Janssen and his discoveries seem to be, I guess, in essence, corrupted. Today in today's illicit drug market, but it's become very sophisticated. Then is what you're saying, and price conscious, and to the illicit drug consumer, even the little guy's gotten squeezed out, Michael. It seems like by the large manufacturers in China and Mexico, the drug cartels have kind of gone corporate. No longer farmers, just laboratories have seemed to taken over.
You're telling me that I can't use the grow light that I've got in my closet anymore to produce mass drugs?
I think those days are behind us. Yes, unfortunately.
What
Sorry.
a bummer.
Yeah. Unfortunate. Those days passed us. Why do you think, though, it does? Part of this, we've seen the cases, opioid overdoses and overdoses in general are staggeringly higher in the last year or two. 20-30%. Is that accurate, Dr. Taca? Somewhere there? What are the stats on that?
Yeah, what we're seeing is the last stats came back ending November. The last 12 months ending November, we saw the highest amount of overdoses associated with opioids and methamphetamine compared to any other 12-month period during the epidemic. I think the numbers were over 100,000.
It seems like if they're killing their customers, that's not good business. That's not good business. I mean, I know. It seems like by mixing this methamphetamine, is there some reason? Why are they doing that? What is the? Is it driven for those on the streets? That's what they want. Are the drug dealers just? I don't understand why the switch to this mixture of the two drugs. And I've tried to read and I can't figure out, Mike. I
Mike.
don't know. You know, Dr. Taca.
You know, Dr. Taca.
It seems like that it would, by putting it in cocaine and by putting it in marijuana, all these things, that would just have massive death on the marketplace. Any
Yeah,
answers to that?
Any answers to that?
Yeah, there's a few reasons why there's a lot of overdoses, especially with fentanyl. Fentanyl is 100 times, or sometimes depending on the type of fentanyl and its analog, 1,000 times more stronger than morphine. When it gets distributed, the reason why it's such a it's very appealing to a drug distributor to distribute fentanyl is because it just takes a little bit to get the intended result, intoxication. So when it gets to the drug dealer has to step on it. You know what that means? You have to, dilute it, because pure fentanyl, just a little bit, can kill you. So when it gets to the distribution points, when it gets into the United States and it gets distributed to the street dealer, they have to step on it and dilute it. They dilute it a lot of ways. And the reason why they do that is they don't want to kill the customer, because if too much of it can lead to overdose, so they have to dilute it. So the process is quite remedial. If I talk to some of my friends in the DEA, and they often talk about when they get when they find a bust, or they get find a dealer. There's always do you know what a magic bullet is? You heard of a magic bullet? It's a small thing that you can chop up vegetables and
the thing in the kitchen.
Yeah.
Sure.
Yeah, I thought you were talking about drug paraphernalia. Yeah.
Well, it's turned into a drug. Yeah, it's turned into a drug paraphernalia. I mean, that's the main tool they use to step on it. And as you can imagine, it's not always the same potency. Sometimes they'll see dozens of these magic bullets in drug busts, and you're depending on the skill of the street level drug dealer to determine the potency of their product. And a lot of times they don't get it right, and that's why you see when there's a rash of overdoses, oftentimes it's the recipe is not quite as accurate as they wanted it to be. And they'll have testers too, where they'll have testing their product, and these people are usually dependent on fentanyl, and they'll happily test the product for you. If they survive, then it's good for distribution. If they overdose, well, that's what happens.
They're cutting fentanyl essentially the same way they used to cut cocaine with baby powder or baking soda. They're using cocaine or weed or heroin in place of the original drug to cut fentanyl down, essentially.
Yeah, absolutely. There's some enterprising people that are cutting methamphetamine with a little bit of fentanyl. And the reason being is because if you give somebody methamphetamine, they're not quickly addicted to it. But if you add a little bit of fentanyl, it keeps them coming back, because you get more addicted to it quickly. And they may be coming back for methamphetamine, but it's the fentanyl they get quickly addicted to. And so it's not unusual that both are always present in toxicologies and in autopsies when somebody's overdosed.
Okay, so that's a big change. So now that explains a lot to me. So you just they're putting a little bit of the fentanyl in there. That's bringing their customer essentially back. They have a strong desire for that, or a stronger desire for that, even though they might have first gone for the methamphetamine. Is that accurate?
Yeah, that's true. I mean, that's one reason. I mean, the question was why are they why is there so many overdoses, and they're apparently killing their customers? Remember, this is much easier to get into the borders than big pounds of shipments of black tar heroin. So we just have just an overabundance of supply. There's no supply chain issue with fentanyl. It's getting in. And so we just have more product in and on the streets today than ever. It's just easier to put it in your pocket versus, carrying it, on a boat. It's easier to smuggle in. And so the result is we just got a lot of product of this high grade fentanyl for sale.
And so in the earlier waves or wave of the opioid epidemic, you mentioned it was a lot of suburban people. Has that changed, or is it still an issue for suburbia? Does it still have the same democratic
Yeah,
problem with people from all classes?
it
All
is. It
socio.
is. I mean, yeah. I mean, historically, if you think about it, the methamphetamine, they came from a different social strata than opioids, right? But now the two forces have become one. And so now people who used to only use opiates have now become a methamphetamine dependent, and vice versa. This wasn't the case 10 years ago. Methamphetamine was, like a biker and in the gay club scene. And then you saw it in the central states, namely Missouri. You saw a lot of methamphetamine distribution and manufacturing in the central states. What's different now is the methamphetamine itself is different. Before it was ephedrine based. You can get it from cold preparations over the counter, and we've cracked down on that. Made it very difficult to buy large amounts of ephedrine in the pharmacy. So they've turned to other chemicals. They've turned to different, like kerosene or something like that. I don't exactly know, but there's a new process. It's called P2P. And that's what's on the streets now. The methamphetamine is a total different methamphetamine that we saw 10 years ago.
More potent, more toxic. What?
Less
Yeah, yeah, absolutely. It's totally different. Now, if you remember how pain pills was used, right? They used it to get high. They used it. They had it at parties. And they distributed it, and kids were using pain pills. And the way the heroin took over, it forced all the people that were, I guess, enjoying pain pill use, and it drove them to isolation. The heroin dependent people were shooting up alone, and they were overdosing alone. And so we're seeing that with methamphetamine. I mean, this is a different methamphetamine. People are not enjoying the high of methamphetamine. It's leading them to psychosis, isolation. People are not. Cocaine was a social thing, right? This drug is not social. It'll drive you onto the streets, homeless, psychotic. We're seeing a lot of psychosis. We're seeing a lot of people coming in thinking that they're schizophrenic, but the paranoia, the delusions, the voices mostly are induced by methamphetamine.
I saw an interview with Sam Quinones, the author that I know you followed. MJ, I don't know if you read any of his books about it's a really interesting author who's done a lot of work in the opioid crisis. And he said, a little tongue in cheek, yeah, they've taken the fun out of a recreational drug. There's nothing fun any longer about this for people. People are dying who might innocently have thought, oh, I'm a young person. I'm fearless. I'm going to do some cocaine as generations have done in the past. And people are dying quickly. And I guess they're not even have a chance to really take steps into recovery. Is that accurate, Dr. Taca?
Yeah. The people that we're seeing now, actually during the pandemic, it's been interesting. I've told you this before. Despite the fact that we're seeing reports of increase of overdose from opiates and methamphetamine, our little clinic, which is a small sample of the people looking for treatment, we're not seeing much of the people struggling with methamphetamine or opiates. We're seeing almost exclusively upwards to 90% alcoholism. And for years before the pandemic, it was pretty split down the middle, 50-50. But it was surprising to us that we were seeing most people coming in for treatment for alcohol. And it was interesting. I in the beginning, I couldn't explain it. I said, well, the numbers don't, I mean, the numbers are saying that the more people are using and dying from opiates, and we're not seeing any. Well, I was reading I think it might have been Sam Quinones, or somebody that was interviewing him, and they had mentioned that Sam Quinones, I believe, was talking to a judge and trying to figure out what's going on with these new drug dependent people, and the judge said that they're not getting to them. They're overdosing before they can get the treatment.
Wow, that's a big change. That's a big change, because the drug courts have actually been a great place for people to find a sense of rediscovering sobriety and been really effective in working for people. And if they're not even getting into the drug courts, that's a big shift.
Well, I think you've got
Absolutely.
Sorry, Dr. Taca. I think you've got something weird happening too, where it's people that aren't intending to do fentanyl or heroin or anything that would quote unquote, be addictive over the long haul. People that are doing party drugs like cocaine that just snap and die after doing, a line of cocaine because there was fentanyl in it and they had no idea. Those people never had a chance coming either. And then I assume that people that do make it past that first experience, that wake up the next day and they're like, man, what's wrong with me, are the only people that are ending up in that 10% that you're seeing in clinic, or whoever makes it to the drug courts at that point. Is that pretty fair to say?
Yeah, it grabs you quickly. Absolutely. This is the most toxic combination of drugs I've ever seen that's available on the streets. Yeah, I would have to agree with Sam Quinones. People historically use drugs or drank to quote unquote have fun. There's nothing fun with this combination. It quickly hijacks you, and in psychiatry we talk about something called a downward drift, where mental illness can bring you down to homelessness. This is no different, and we do see this signs of severe mental illness with this combination, especially psychosis. And we see, because of the paranoia, we see people driven to the streets. We see people not taking care of themselves, psychotic, not taking care of themselves and their hygiene, losing their teeth. If you can imagine using methamphetamine, they're up for days, and they have strange little quirky behaviors, like riding a bicycle around the streets for days, just kind of hoarding things that they can pick up on the streets, and bringing them into their and onto their tents in the homeless camps on the streets of the cities. It's terrible. It's absolutely terrible. There's nothing social about this movement. It's pure toxic psychosis. It really is.
Here in Texas, I'm going to pull up something. MJ, Houston's fentanyl crisis spreading like a brush fire, DEA says. And this article just a few weeks ago, a DEA agent said 4 out of every 10 pills on Houston streets right now are laced with the drug fentanyl. And dealers are adding it to heroin, cocaine, and counterfeit prescription drugs. Most victims are dying after taking these pills, not even knowing what they're taking is laced with fentanyl. So even prescription drugs they're mentioning further down in this article are in fact being, I guess, fugazis for the that are fake. And you're right, they're getting into these unsuspecting people's hands in some cases, and they're dying. 4 out of 10. That's staggering.
Yeah, absolutely. I mean, anything that has street value historically, there's a lot of things you can get on the streets, including Adderall, Xanax, Suboxone, and anything that can make you feel different. And there are pill presses that'll make it look exactly and have the stamp of the brand on it. And if you want to get some Adderall, it'll look like Adderall. And the problem is that it could be laced with fentanyl and other adulterants. There was a case here in St. Louis where I think 6 or 8 people died all in one from one dealer. And this dealer was not an opiate dealer. She was known to be like a cocaine or methamphetamine stimulant dealer. All of them were looking for cocaine because they didn't have any tolerance to the fentanyl. They all overdosed. And the cocaine dealer didn't even know she was dealing, she thought she was dealing her normal stimulant supply.
So she's not the one with the press then. Is that something that happens before it crosses the border most of the time, or do you know?
Yeah, I think in this case, she was just a low level distributor. She didn't have any, I do not believe she had a manufacturing.
Is that pretty, or is that something that always happens once you get the raw product into the United States? How does that go down?
In the city, it can go both ways. I mean, a lot of the stuff can get cut at the level of the city, and be you can have your own little compounding pharmacy, run by amateurs, and but sometimes it's already manufactured and stamped and pressed, coming in completely. From out of the country.
Are there any places across the United States that are doing well? I know this is very widespread. Is there anything that we can point to, any communities that have taken a different approach in the last year or two and said there are some solutions? Is anybody aware of any of those?
Well, there are a few. I think I read an article. There may be 3 states where the opiate the overdoses were not increasing and actually decreasing. There's always opiate overdoses in every corner of the United States. But I think the states were just a handful, maybe 3 or 4. I know some states are a little bit more ambitious about creating innovative solutions. I think there's some states have finally opened their doors to needle exchanges, and even actually giving the actual heroin to a safe injection space, like Canada had been doing.
Would you have to give them fentanyl then if they've already had fentanyl? If their tolerance is built up? I mean, is that what it's come to? Or do we have now, instead of, are we then giving somebody who's in that situation a supportive dose of therapeutic dose of fentanyl? Or or does that person get weaned off of fentanyl at those centers? How does that work? And I'm not curious about.
I don't know exactly what type of opiate. That's a good question. A lot of times it may be methadone. Methadone is something that it's been available to the drug dependent population for a long time. It's safe, and they'd rather have people on something licitly than illicitly. And as far as needle exchange, when people get clean needles, they're not just getting their supply of clean needles. They're being talked to and they're being asked, hey, do you want to be transition to methadone or Suboxone, or perhaps be detoxed, or even go to a comprehensive drug treatment program. So they are talking to them. I guess they're meeting them where they're at, and as long as they're coming for their needles, they're always having discussions of potential treatment.
It's a good touch point to actually get a hold of those people.
Yeah, yeah. And I know there's a lot of opposition to this because some people feel like that you're supporting their habit. But in other countries, we've seen this work. We've seen the rate of hepatitis and HIV be controlled, because those illnesses are can spread like a wildfire in that population because of the use of unclean needles. So and if you have hepatitis, I mean, it's at least $1 million of medical treatment. It's a very expensive disease to treat. So they've been able to reduce the spread of these common viral diseases in this population. So it does work.
Do you think that those same kind of tactics are going to be as useful in the fourth wave as they have been in the earlier ones, though? Because if, like we were saying before, your patients don't really make it out of the gates to start the race back to sobriety, are you optimistic that the same type of tactic gets you there?
That's a great question, Mike, because we're dealing with a more powerful, more psychoactive combination of drugs. We assume that if we can infuse some logic to the person who's dependent on the drugs, they may one day agree to treatment. But we're seeing the psychosis associated with methamphetamine and the opiate combo is so powerful that I'm not really sure if they'd be able to consent or be competent enough to understand what treatment is. They oftentimes are bothered by delusions and paranoid thoughts and voices. And
is that psychosis? Is it temporary? Is it long-term? How acute is it? Or does it vary for those patients?
we don't know. We don't know. We will find out. I have one patient right now that had a few years experience with methamphetamine. We got her clean, and she's showing signs of psychosis, and we sent her to the hospital. The question for us is, has she always been, is this a form of psychosis that's always been brewing, like schizophrenia or bipolar with psychosis, or was this drug induced, or has it switched flipped a switch that has made this person permanently psychotic? Because we've done drug screens on her and she's completely sober. She's doing what she needs to do. But now she's coming to us complaining of voices and paranoid thoughts that people are, getting into her cell phone, and, just the common things that you believe when you're, under the influence and paranoid. So we don't know. I mean, what we know is, the methamphetamine affects the brain differently, and it actually changes the brain's structure. If you use methamphetamine for a long time and you do brain scans, the actual, I mean, it looks like Swiss cheese. There are, and could those brain changes be permanent? We don't know. This is a new drug, and then the amphetamine is made differently. Like I said, it's made through a process that's it's called P2P. It's bad shit, boys.
Is there so there aren't any studies on old bikers that were running around in the 70s and 80s that were doing meth that we know how long the dysregulation of the brain is or what the effects are?
I think even if there were, this is like the old thing of, this is meth but on steroids now, is what I think Dr. Taca is kind of telling us. It's a totally new beast.
Yeah, it sounds like it.
It is a new beast.
It's whole new beast and an ugly beast. We don't know what's in store for us yet. So this is really good news, Dr. Taca. I mean, here we come out of COVID, where is there something that COVID contributed to to also increase interest or levels of use specific to COVID that anyone's talked about? Or was this just always brewing and now we're paying attention to it?
I think we learned a lot of lessons from COVID, and no doubt about it. COVID has put mental health on the stage. Generally speaking, there's been more depression, there's been more anxiety, there's been more isolation, there's been more child and adolescent suicide attempts. Independent of the drug issues and the opiate epidemic, more people are depressed, more people are worried. As far as alcohol, we saw a big jump in alcohol use because you could drink alcohol at home. You could order alcohol and get it delivered, and I know a lot of people would drink coffee in their cups like this and pretend that they're drinking coffee, but it's full of alcohol, you see. So we have seen, and primarily we saw a big jump in heavy drinking days in women. The stats showed a 41% increase in women specifically during the pandemic of heavy drinking use. And we saw that in our private practice, in our treatment program. We saw, again, almost exclusively, and it's still happening today. People are seeking treatment for alcohol. So as far as the opiate and the methamphetamine, what did COVID do? I think the distribution networks have always been there. I don't believe that there was any problem getting the raw material or the finished material into the borders. And unfortunately, America is addicted to drugs, and China knows it, Mexico knows it, and until we address it at that level, and accept that our brains are, we as customers are the best customers in the world for them, because we want instant gratification. We want a pill for everything. They know that we have a voracious appetite for drugs and alcohol. We as providers and clinicians can do so much, and give them antipsychotics and anti-craving medications and do therapy and do group therapy and things like that. But until we address at a government level how we can slow this down and have the cooperation of China and Mexico, I don't see this slowing down.
Yeah, there's something obviously culturally in American Western society in particular, but unique to the United States. We use 90% of the antidepressants, correct? We are more pharma based in our treatments. I'm sure that stems from also how physicians are trained or educated. But I guess it's a bit of the chicken and the egg, right? Is it the patients that want it, and that's why we teach that way, or is it top down? I don't know. It's very complex, but we do have it in abundance. Pills, alcohol, opioids. We are an instant gratification group.
We are.
MJ,
we've got dozens of antidepressants on the market, and suicide and depression has not slowed down; it's actually increased. So, what's going on?
MJ, do you see? You're younger than Dr. Taca and I. What do you see from younger people? Do you see any difference? And you're in the medical industry, but socially, last 2 years, do you see more people that were drinking just on observance, cocaine amongst socially out at parties and stuff like that? Is that something that's culturally acceptable? People are doing it.
It's probably more like just my circle type of thing, but I don't think I've seen a ton of cocaine, and this is definitely just my circle, ton of cocaine since college type of stuff. I will say that obviously in the pandemic, just like everyone that Dr. Taca was talking about, we drank a lot more. just had to kill time almost at some point. And, you know, if you have a tendency to become hooked on stuff, I think that is pretty dangerous. Luckily, I don't think, as far as I know, anyone in my immediate circle is really grappling with that as far as alcohol goes, at least. But yeah, I think not having to show up at work 5 days a week and not having to, you know, check in with the man really did open the doors for more drug use and alcohol abuse and that kind of stuff in my tier of people.
Yeah, no, that makes sense. I mean, when you take out compliance and different things and seeing people all the time and isolating more naturally, when you're incentivized, you're told to isolate, maybe the wheels fall off, right? In some
I
other,
certainly think so.
yeah.
I mean,
yeah.
I grew up in Plano in the 90s. The kids that were like 5 to 10 years older than me were the kids that made the national news with the heroin and cheese epidemic. And that was kind of the first awakening I would have had, you know, being a 10, 15-year-old kid, was, hey, there's this drug out there that's causing people to die when they're taking it, you know, and they're not taking it at parties, they're taking it alone. And then that kind of also dovetailed in with the suicide epidemic that was happening in North Dallas around that same time frame. And I will say that that's probably scared a bunch of people in my immediate circle pretty straight as far as, you know, meth or cocaine use is going to go. I'm also not in a biker club, but you know, these things I think have definitely ramped up, and it's not quite to the levels that it was before, like 20, 30 years ago, I think, in North Dallas, but I think we're seeing it across the country a lot more than I would have ever expected to see again, you know?
Right. You're not in a biker club yet.
That's very fair. I have not. It's, you know, with gas prices going up, someone sent me a motorcycle. It looked really kick ass, and it was like 15 grand. And I was like, I could get a leather vest, you know, I'd look good in that, I think.
That'd be awesome. You could ride in down the tollway on your bike.
Yeah.
You'd have a tough time putting those sets on the bike though, taking them to the hospital,
Maybe
right?
a little trailer or something. I almost don't. Do you need a toll tag if you're on a motorcycle? How does that work?
It's a great question. I think you look kind of like a wuss though if you have a trailer. I mean, I don't want to have bikers all mad at me, but
I could do a sidecar and just put all the sets in the sidecar.
a sidecar.
Yeah.
And your dog could be in the lab, could be in the sidecar.
Yeah. It's more of a like nostalgia throwback type of situation than it is, you know, practical, right?
Yeah. Yeah. I don't know. I don't know what your gal would like. Because she's a Toyota girl. So she's got to stick with the cars and the trucks.
Just get a Japanese motorcycle.
Does Toyota make a motorcycle yet?
Maybe they used to. I have no idea. I don't think they're running one right now, but
maybe an electric one.
Yeah. They're about moving
There you
people.
go.
That's the tagline.
That's their tagline.
It's something like that. Yeah.
Maybe
They're a movement company, something to that effect.
Wow. I was going to say maybe we get some money for them for putting this out there, but I don't think with that inspirational.
No, we'd have to rehearse the tagline a little bit more than there may be a moving company for people.
Right. Exactly. Well, Dr. Taca, thank you for your time today. Anything other than the opioid fourth crisis? Any ideas as to what people who are listening to this can look for, or where this is heading, or are we just going to stay tuned and see how this evolves?
Well, one thing that I want to make sure that this is a terrible situation with this, you know, evolving situation with the new drugs on the street. But with that being said, there is effective treatment available. So if there's any signs of somebody kind of messing with any kind of drug or drinking, there are very effective FDA approved medications along with behavioral modifications and behavioral therapies. And yeah, you can abort this this illness stop it in its tracks and prevent an early death. We got a lot of good medicines out there. We've got even devices out there that can help with the withdrawal of opiates. And so find somebody that has experience in addiction medicine, somebody who understands the available treatments out there that are FDA approved. There are medications that are very effective, just as effective as medications for blood pressure and diabetes. So there is hope, but yeah, this is a very deadly situation here. But
You're
there is
kind
hope
of
and treatment.
Sorry, you were kind of touching on that a little bit, but how, not specifically your practice, and if you want to plug your practice, please do, but how would you go about finding a doctor that does what you do? Say if you live in like Seattle, New York, somewhere, far flung, but with this issue.
Well, there's a society out there. It's a medical medically recognized society. It's called ASAM, the American Society of Addiction Medicine, and physicians can be certified as an addictionologist and become an expert in addiction medicine. You can Google addiction specialists in the area. If you were in St. Louis, you'd bump into my practice in synergystl.com. And you can call us at 314-649-STOP, STOP, 649-STOP. But that's what I would start. I would look for people who are experts at treating addiction, understand the need for detox, medically supervised detox, if that's needed, because the withdrawal of alcohol could be deadly, and the withdrawal from opiates is the main driving force of getting more opiates. So you want to stop that cycle by detox and then transitioning them to medications that could help with the craving or even block the effect of other opioids.
That conversation that a loved one has when you said they see the signs of that, what are some of those signs that someone, when they call you, relates to you? When people are suspicious of that, there might be some hesitancy to interrupt some other person's life. What are some of those?
Well, it depends on what you're struggling with. Alcohol, obviously, if you're you can just tell if somebody's drinking on the job, slurring their speech, and then neglecting their responsibilities. I think that's something that happens when any drug or alcohol kind of takes over and hijacks the brain. If there's signs of withdrawal, when they're always kind of sweating and they always feel like they have the flu, that can be a sign of withdrawal from opioids. And isolation, if they're not connected, if they're just sleeping all day and up all night, and then if there's a change in their behavior, anything unusual, you should start peeking around and see if they're leaving any evidence of any drug use or alcohol use disorder. It's a hard conversation to have. It's a hard conversation to start, because you don't want to be accusatory, because once you do that, they tend to sometimes be defensive and run away. So, maintaining a neutral stance, a stance of concern, and always meet them where they're at and ask them if there's anything you can do to help. And because, deep inside, they won't say it, but they are suffering. No one wants to wake up and admit that they have no control of their life. And there's a lot of shame and guilt when that happens. And that's why you have to be careful, because if you're antagonistic to them, they're already embarrassed and ashamed of their situation, they're just going to run away. And they're suddenly not going to be your friend. So their friends are the ones that understand, the ones that they drink with, or the ones that they use drugs with. So, the approach is important, meeting where they're at, and keeping a very neutral stance, and voicing concern is usually the safest and most effective way.
Excellent. Great advice. Thank you, Dr. Arturo Taca. MJ, anything to add?
No, I think we covered quite a bit about this new wave of the opiate crisis.
We have indeed. Thank you both for your time this evening. And
Of course.
We'll talk to you again soon.
Thank you both.